Dr. Parul Raina is Assistant Professor in the Department of Anesthesia at Sharda Hospital, Uttar Pradesh. She has obtained her bachelor's degree from Belgaum, Karnataka, and completed her master's in anesthesia from Jammu in 2019. And currently, after obtaining further experiences, she is now Assistant Professor at the Sharda Hospital. And she has such a keen interest in chronic pain and palliative care, which is essential and very nice to see someone of that interest and who is also willing to help Pallium in the teaching sessions also. Today we are going to have an important topic which will seem difficult and strange to begin with, but it can be dealt with and tackled very well if done appropriately. That's what she's going to help us achieve that through her session today. With that, I hand it over to you, Dr. Parul Raina.
Thank you, ma'am, so much. Good evening, everybody. So the topic for today is delirium. And I believe everyone must have seen a patient of delirium in your clinical setup. I will try to share my screen. Okay. I think there is some issue. Can anyone at Pallium and...
Yeah, sure, ma'am.
Anup, will you be able to... Have you sent the presentation to them?
I do have.
Okay. Anup, in that case, could you... Yes, there he goes.
Just give me a moment.
No problem. We can see the presentation. Thank you, Anu.
Yeah. So let's begin with the topic per se. Ma'am, just for the info, is there any case presentation later on? Because I couldn't see anybody's name case presentation.
See, there are two presentations, Dr. Parul, but unfortunately, both of them have said that they won't be available to present. Okay. Ideally, it will be good if they are there to present. But if you can go on with your presentation for all the time with discussion, one option. Okay. Or I can read, because both the presentations, both the cases are good. I can read one for you. We'll see as it goes.
During my presentation, I have actually added one case history.
Okay, then.
So we will see how much time I will be taking and how much time.
No worries, dear. See, we are flexible. We want to convey the message, and the platform is open for them to interact also.
Yeah.
So that it's a two-way thing. If you have the case and it goes on, well and good. We'll take it as it goes. Okay. Is that okay?
Yeah, sure.
Thank you.
Yeah. So let's begin with the delirium topic per se. So the word delirium is actually from the Latin word deliriere, which actually means to go out of the furrow and actually means to go away from the, deviate from the straight line. Next slide. So the important point to remember is that the delirium is a neuropsychiatric syndrome. So it will have multiple symptoms and signs caused by transient disruption of normal neuronal activity, which is secondary to systemic disturbances. Next slide. So the two critical features that one should remember while dealing a patient delirium or diagnosing a patient delirium is that it is acute in onset and the symptoms are fluctuating in nature. Like within a day, the symptoms will be on and off. Coming to the epidemiology per se, delirium is considered as the most common neuropsychiatric disorder in patients with advanced illnesses, having a prevalence of 13 to 93%. So you can see the vast range of prevalence of delirium in our clinical setup. Though in 25 to 68% of the cases, it is reversible, but in advanced illnesses, it is not, where it is considered as the sign of impending death. So approximately all the patients will be having delirium hours to days prior to the death. So this delirium is considered as the major distress for family members, staff, and in fact can interfere with the recognition and control of other physical symptoms like pain. Before I will be talking about this case, I would just want to have a little interaction. So all the doctors which are present among us, can you just please share the clinical setup where you have seen the delirium in your clinical practices? So we will know, we'll get the places and all where we can see and find delirium patients. Can anyone just use the chat box, or you can just say it loud? Yes, I see you. Uremic encephalopathy. Yes. Where all? In what case scenarios you can find delirium? Exactly. Nice. End organ failure like uremic, hepatic, hyponatremia, COPD. Yeah. Post-operative. Lovely. Yes, poisoning cases, shock patients. So yeah, let's come to the case per se. I'm reading all your comments. We'll continue with our case also. So Mrs. Smith, so sorry, give me a second. Yeah. So this is a case story of Mrs. Smith, who is an 88-year-old woman having end-stage heart failure and has a history of type 2 diabetes mellitus, osteoarthritis with numerous urinary tract infections, and uncontrolled hypertension. She had been hospitalized previously 4 times in the last year for exacerbations of heart failure. She recently has fell at home, fracturing her right hip, and underwent surgery to repair her hip. Now she is presented to you 2 days post surgery. She has become now disoriented and frightened and wouldn't follow nursing instructions. She's periodically lashing out at her caregivers and is not recognizing her husband. She knew what year it was, but she couldn't tell where she was and how she got there. She needed constant reminders to stay in bed. She still had an indwelling bladder catheter. She was almost awake most of the day and half of the night, vacillating between agitation and lethargy, and not quite understanding why everyone was making her to do things that hurt. She has received her pain medication around the clock and was able to report her pain levels when asked. But she couldn't hear, as her husband had taken her bilateral hearing aids home because he didn't want her to lose them, and her eyeglasses were lost in the emergency department. So with this case history, we'll proceed with the etiology of the delirium, and let's see how this case went. Next slide. So for delirium to occur, there are certain predisposing factors which combined with precipitating factors leads to delirium. And delirium is considered as a leading cause of poor health related outcome. So let's see the predisposing factors and the precipitating factors. Next slide. In the predisposing factors, we have older age, cognitive impairment, visual or hearing impairment, functional impairment or immobility, decreased oral intake, any past history of delirium, polypharmacy, any coexisting medical illnesses, old age, physical frailty, surgery. Whereas in precipitating factors, there is acute illnesses like infection, pneumonia, sepsis, MI, shock, dehydration, metabolic abnormalities like some among you already mentioned hyponatremia, drugs like sedatives, narcotics, alcohol, and overdose of tricyclic antidepressants, corticosteroids, and anti-Parkinson's disease. And in precipitating factors, we also have like environmental factors like use of physical restraint, use of catheters or invasive monitoring, surgery, and pain itself, and prolonged sleep deprivation. Next slide. So this is the table. I will not go in detail. This is just for all of you to remember the predisposing and precipitating risk factors with a mnemonic and acute brain failure. This is all the summary of the predisposing and the precipitating factors. Next slide. So yeah, next slide. After etiology, what is happening in pathophysiology is, this was described by the Maldonado, which is considered as the hypothesis of systemic integration failure hypothesis, where there is a systemic triggers like systemic inflammation, hypoxia, blood flow decreased, and metabolic derangement, leading to a neurotransmitter disturbances along with alteration in the neurotransmitters like decrease in acetylcholine or increase in dopamine, along with the failure of the interconnected brain systems, leading to the synaptic changes and impaired neurovascular coupling, leading to delirium. Next slide. How we are going to diagnose delirium clinically. Next. So delirium is clinically diagnosed by the Diagnostic and Statistical Manual 5 criteria, where all of the following should be present. So what it is? There has to be a disturbance in attention, disturbance in awareness, disturbance in cognition, and importantly, these disturbances are occurring in an acute onset within a very short period of time, and it is fluctuating during the course of the day. One has to remember that these disturbances in attention and awareness are not better explained by any other existing or establishing neurocognitive disorder, and it doesn't occur in the context of severely reduced level of arousal such as coma. And there has to be an evidence from the history, physical examination, or lab finding that all these disturbances are a direct physiological consequence of another medical condition like substance abuse, substance withdrawal, or exposure to a toxin, as we have already seen in the last slide. Next slide. So clinically, phenotypically, the delirium is classified into hyperactive, hypoactive, and the mixed type. Hyperactive is predominantly restlessness and agitation, where there is an increased motor activity. The patient is restless and wandering. Whereas in hypoactive, the patient is predominantly drowsy and inactive. So the mixed variant is the combination of hyperactive and the hypoactive, which has to be occurring within a 24 hours period of time. So if I ask you, which type of delirium among three is commonly not diagnosed or underdiagnosed, what will be your answer? Can anybody tell? Yes. Lovely. Yes, it's the hypoactive one. Why? Because we often confuse the hypoactive type for depression and dementia. Yes, lovely. Everybody know well. Yes. So yeah, what is important for us now to understand the differential diagnosis for delirium as well. Next slide. Next slide. Okay, before coming to the differential diagnosis, let us go back to our case history. And from the case history now, can you just point or tell me, jot it down, what all the precipitating and the triggering factors or underlying factors were there with Mrs. Smith leading to delirium? There's only one mark. I'll be waiting in the chat box and then we'll be discussing. Yeah, number one, elderly female. Yeah. What else? Yes, age. Next. What were the predisposing factors? Yes, multiple comorbidity. Triggering factors, catheter. Yes, heart failure. Frailty. Yes, diminished vision, hearing, impaired hearing. And importantly, yes, Kamakshi, it is a post-operative also. Catheter in situ, lost her glasses. Yes. So, can you just press it down? Next slide. Yeah. Kindly please pressing it also. All these factors which I've already discussed will come up. Yeah. Yeah. Yes. So all of you have already mentioned. Yeah. Pain. She is receiving pain medication. So we don't know whether she is getting over treated or under treated. Great. Next slide. So what is happening with Mrs. Smith was on day 3, she was exhausted and couldn't assist with her personal care. Her husband came to visit and tried to wake her, but she just opened her eyes and stared blankly at him. She has not used her Insetti spirometer because it was just on the floor, and her husband now was in distress because he is finding that his wife was not herself, and he couldn't understand what was happening. Now, nurses are complaining that Mrs. Smith is too hard to care for and that she must be having dementia. But Mrs. Smith, before getting hospitalized, was very adamant that she was tired of going to the hospital and being so sick, stating that she just wanted to go home and surrounded by family and friends. Next slide. So, what is happening here is, without any proper evaluation, the nurse directly diagnosed Mrs. Smith as dementia. This is what happens when we often deal with delirium. We confuse them, we label them as the patient is agitated or confused, and we don't evaluate or try to find the reversible causes for delirium, hence leading to the very poor outcome. Next slide. So, differential diagnosis includes the anxiety, psychosis, depression, and most importantly, delirium is often mistaken with dementia. So let's see, how do you distinguish between delirium and dementia? Next slide. Delirium is abrupt, whereas dementia is usually insidious. The course of delirium is usually fluctuating in nature, fluctuating within a day also, whereas dementia, it is a very slow decline. Duration is within hours to weeks, whereas in dementia, it is months to years. Usually attention, sleep wake is all impaired in delirium. And the most important point to distinguish between delirium and dementia is the alertness level. In dementia, it will be normal, whereas in delirium, it will be impaired. So with that, we now know that Mrs. Smith was not having dementia, but delirium. Let's go ahead. Next slide. On day 4, Nancy, who was Mrs. Smith's daughter, came to visit after her father had called her to express his deep concern and worry about his wife's condition. So now you're seeing that because of Mrs. Smith's condition, her daughter and husband now getting distressed. But here, now the nursing staff assessed Mrs. Smith using the CAM tool, which is used to assess and screen the delirium, and she was diagnosed delirium. And they kept on assessing Mrs. Smith at least 8 hours apart. Nancy, her daughter, also works with the older adult population in a hospital and immediately suspected her mother was experiencing delirium. Now, what is happening is that the nurse and the Nancy, who is the caregiver of the patient, are taking a shared decision. The healthcare staff is including the caregiver also and discussing what were the triggering factors for Mrs. Smith going into delirium. As we have already discussed, it was advanced age, severity of the illness, comorbidities, diminished vision and hearing. And there were precipitating factors also. Use of numerous medication, immobilization after surgery, dehydration because of the nilperoral after surgery, malnutrition, and indwelling by the catheter, which is a risk for UTI, and sleep deprivation. Next slide. Let us see what are the various assessment tools with which we can diagnose or screen and look for the severity of the delirium. As I've already mentioned, the basic and the most important step in diagnosing the delirium is the clinical diagnosis, which is by the DSM-5 criteria I have already discussed. Next slide. So, the majority it is by the clinical diagnosis by DSM-5 criteria. And now there are various tools which are used like CAM, CAM ICU, and there are certain other variants of CAM. There is DRSR-98, mini mental state examination tests, which is used to rule out the organic cause from the psychiatric causes of the delirium or disorientation. There is SQUID test and the 482. Next slide. And importantly, one has to remember just by doing one assessment is not enough. We have to make sure that in a day we are having a 1, 2, or 3, at least 2 to 3 assessments to evaluate and diagnose a patient with delirium. Why is it so? Because we know that delirium symptoms have a fluctuating course. Next slide. You probably might not be able to see it well. This is just the summary, the tools, the screening tools, which includes mini mental state examination, delirium observation screening tool. There is diagnostic instruments like CAM, CAM ICU, DRSR-98, and then there are tools to assess the severity of the symptoms using MDAS, which is Memorial Delirium Assessment Scale, Bedside Confusion Scale, and Delirium Index. Now, with the NICE guidelines, the 480 tools has been validated for diagnosing the delirium. Next slide. So this is the 480 tool which is used for assessment of delirium. The number 1 is alertness. Next is we'll be asking the patient to tell the age, date of birth, place, and current year. And it is accordingly scored between 0, 1, 2. Alertness is scored between 0 or 4. Attention, by attention, we will ask the patient to tell the months of the year in a backward order starting at December. And if the patient can achieve 7 months or more correctly, it is scored 0. But if this patient it is less than 7 months or refuses to start, it is 1. And if it is untestable, it is 2. And the last one is the acute changing or fluctuating course. No is 0 and yes is 4. Next. And accordingly, it is scored. Next slide. Yeah. So if it is 4 or above, it is a possible delirium. If it is ranging between 1 to 3, it is possible cognitive impairment. And if it is 0, it is very unlikely. Next slide. This is again the summary of the tools for delirium detection and assessment, showing the time taken, that in which tool the training is required, where all you can use this, and what is the sensitivity and the specificity. Earlier, usually the CAM tool is used significantly. As you can see, it has a specificity of at least 63 to 100%, with a sensitivity of 46 to 94. The 480 tool takes less than 2 minutes with no training required. Anyone can do it in any setting with a sensitivity of 86 to 100%, with specificity between 65 to 82. But yes, it is not helpful in detecting the severity of the delirium. Coming to the next slide. After the clinical diagnosis, we can do the investigations to rule out the precipitating factors like CBC, metabolic panel, ABG, thyroid profile, cultural test, to rule out infection, urine analysis for the same, X-ray to rule out pneumonia, ECG and CT brain to rule out any acute changes like infarct or stroke. Next slide. In management, the most important point one has to remember, the goal of managing delirium is the comfort of the patient. And at the same time, you have to provide comfort to the caregivers. You have to inform them, educate them, and include them in the management of the delirium also. The next is we have to correct the correctables. And last is try to minimize the offenders like urinary retention, constipation, pain, and other precipitating factors. Next, please. Early management. In the management, the first step is early identification. Early identification by clinical diagnosis and using the various diagnostic tools. Yeah, next slide. The second step is the risk reduction. The risk reduction is further into the non-pharmacological and pharmacological component. In the non-pharmacological component, let's see what it is there. Next slide, please. Yeah. In the non-pharmacological intervention for delirium management is that we have to minimize the use of catheters, IV lines, and physical restraint. We have to provide early mobilization, look for nutrition and hydration, provide visual and hearing aids, control the pain, monitor bowel and bladder function, review the medications which the patient is taking, look for the overdose, reorient the communication with the patient by keeping the family members around, place the orientation board, clock, or familiar objects in the room, encourage the cognitively stimulating activities like word puzzles, facilitated sleep hygiene, warm drinks and gentle massage at night, try to minimize the noise, and interventions like taking the blood sample, doing investigations, or checking the patient at the bedtime. Next slide. In pharmacological risk reduction, the important point is you have to review the medications with which all the patient is taking, because it's very important to see that if the patient is not having the overdose of any medicines like painkillers, opioids, steroids, right? So yeah, next slide. In the pharmacological management, you have to look for the precipitating factors. Precipitating factors like already discussed, drug-related like opioids, steroids, sedatives, withdrawal of drugs like alcohol, nicotine, benzodiazepines, and opioids. Look for the metabolic causes like systemic failure, hypoglycemia, thyroid dysfunction, adrenal dysfunction, infection, nutrition. Look for if there is any raised ICP as well, and other causes like dehydration, shock, urinary retention, poor sleep, or any other environmental factors. With that, you have to manage the patient. Like for opioids, you can stop and reduce the dose. For metabolic causes, you will try to identify. Like for the respiratory failure, you can provide oxygen so that in most of the cases that can also help with the delirium. For raised ICP, you can start the patient on low dose steroids. And for circulatory pain and constipation, you will manage these features accordingly. Next slide. Yeah. Coming to the delirium management symptoms per se. So the first line of drug which can be used for managing the symptom of delirium where sedation is not required is the haloperidol. We will start the haloperidol in a very low dose of 0.5 mg HS, and we can increase it gradually if necessary with a maximum of 10 mg in 24 hours. If you are suspecting alcohol withdrawal, then there is a role of benzodiazepines. What about the patient who is agitated where sedation would be beneficial? You can start with the olanzapine in a dose of 2.5 mg to 5 mg once or twice. If you require more sedation, you will start with the levopromazine in a dose of 12.5 to 25 mg, 6 to 8 hourly or orally or subcutaneously. If the patient is acutely disturbed, violent, or aggressive, they are at risk to themselves or others, we'll start with the little bit higher doses of haloperidol, that is 1.5 to 5 mg subcut or IM, and we can repeat them as needed after 20 to 30 minutes. In cases of Parkinson's or dementia with Lewy bodies, we have to avoid the antipsychotic drugs. Next slide. This is just once again the summary. So the first line is haloperidol. The second line is benzodiazepines. We can in fact also use lorazepam and midazolam. What about where the sedation is increased and delirium is refractory? I will come to this topic at the end with a very short note. In those situations where you are not able to manage delirium with the conventional methods, or you want the patient to be more sedated, especially at the end of life, you can start with the infusion of midazolam as a continuous subcutaneous infusion in a dose of 10 to 30 mg for 24 hours, or rectal diazepam in a dose of 5 to 10 mg, 6 to 8 hourly. We can switch the haloperidol to levopromazine as it is more sedative, and we can start with the infusion in a dose of 25 to 200 milligram in 24 hours. Next slide. The other drugs which are used off-label are melatonin with a very poor evidence, and there is an upcoming drug, dexmedetomidine, which is mostly nowadays like studies are done in the ICU setup with very good results, and is also used in the palliative setup, but still we need a good RCTs for that evidence. You can also use risperidone and quetiapine. Next slide. So let's see what's happening with Mrs. Smith. So, as already mentioned previously, the nurse and the Nancy, who was Mrs. Smith's daughter, they discussed the numerous risk factors, and together they developed a comprehensive plan of care. The care plan included safety measures to minimize the risk of falling, the discontinuation of the indwelling bladder catheter after a sample was sent for urine analysis, the continuous evaluation of effectiveness and side effects of her pain medications, and respiratory treatments, including assistance in using the incentive spirometry. Her X-ray showed that atelectasis is there in both lower lobes, and there was a consultation on the left side. So antibiotics were started. Antibiotics were also started because she had developed a UTI. Now, the caregiver, Nancy, decided to stay with her mother in her hospital room to provide a familiar presence, because that would help keep her mother calm and oriented. She also helped in her physical therapy. She helped in her mobilization, also assisted her mother with the incentive spirometry. So, since Nancy was with Mrs. Smith, she was receiving and provided continuously food and fluids, and that helped her mother's recovery. And her husband brought in her hearing aids and glasses as well as the familial objects from the home. A calendar and clock were placed where she could see them, and pictures of her grandchildren were put on the bedside table. Next slide. So by 5th day, Mrs. Smith improved. She has started walking, she was alert, she was eating and drinking, and she was ready for discharge. What the palliative care team did, they collaborated with Mrs. Smith and they spent the time with her family to make certain all understood that what were the goals of care. Mrs. Smith was very adamant that she wouldn't go any further diagnostic test or aggressive treatment for her heart failure. She wanted to spend time at home with family and friends. And then they finally, the Mrs. Smith husband and daughter agreed that with her wishes, as they realized she would not want to live if she had no quality of life to do things that brought her joy. Next slide. What will happen? What would have happened that if delirium was not identified on time and not managed well? Next slide. It would have led to distress. Distress for the patient, for the nursing staff, for the healthcare workers, and for the caregivers. It will result in reduced functional ability, leading to increased mortality, morbidity, greater length of stay at hospital, more hospital-acquired infections, more chances of falls, incontinence, and in cases of hypoactive delirium, less reversibility with worse quality of life. Next slide. And this will lead to a delirium destructive triangle. What will happen is that the patient is presenting with delirium and agitation. This will result in distress to the relatives and the caregiver. The relative and the caregiver will then pressure the staff to increase the sedation and analgesia. The healthcare staff under distress will lead to polypharmacy, and more opioids will be given. And ultimately, rather than helping the patient without identifying causes, it will lead to more agitation and hence more distress to the relatives and caregiver, and finally, complicated grief. And this cycle will just keep on repeating rather than helping the patient out. Next slide. So finally, what they did with Mrs. Smith was a written documentation for the goal of care. It was signed by the Mrs. Smith and the family members, so that the next time, if the Mrs. Smith is landing up in the same situation, what can be done at that time without causing much distress to the family and all the caregivers. Next slide. This is all about delirium per se. I will now proceed with a small note on the refractory delirium. Does anyone have questions now? Or will take at the last? Okay, we'll begin with the refractory delirium. So with refractory delirium, there is no universal definition per se. If the delirium is not managed with already discussed methods, conventional methods, then the problem comes. Then you don't know what to do. And that is how the treating physician can label somebody as a refractory delirium case. And here the role of palliative sedation comes. Next slide. So the palliative sedation is always at the discretion of treating physician. It is usually started when the death is imminent and when there is a failure of traditional therapy. There has to be a well-documented goal of care, and this has to be discussed with the caregivers. The problem with palliative sedation is that it still has some ethical and legal issues and even cultural issues also, because it is still compared with euthanasia. How it is different from euthanasia? Next slide. Euthanasia means intentionally using medication to terminate patient's life to end their pain and suffering. It is legal in Netherlands and Belgium. What is physician-assisted suicide? Where physician acts as a facilitator for patient to hasten death by providing lethal doses of prescription medication. Here, the physician will act as a passive role of supervision and patient is an actual administrator. It is done in US, Canada, Belgium, Netherlands, Switzerland, and Luxembourg. What is palliative sedation then? Next slide. The main intention of palliative sedation is to relieve the refractory symptoms, where the desired outcome is sedation level to control the patient's symptoms. Palliative sedation is legal in all the countries. The problem is timing, when you will start, because we still don't have a universal definition of refractory symptoms and prognostication. So you should be well aware the prognosis of your patient, and you should be well equipped to diagnose somebody to having the refractory symptoms. So in that, we will be managing the patient with proportional treatment. By proportional treatment means to relieve the intractable symptom and not to keep the patient unresponsive. So which lead to the phenomena of double effect. The double effect is the beneficence versus non-malfeasance. The benefit of giving palliative sedation to the untoward harm or untoward side effects, which is because of the
Have we lost her?
I think yes, we will wait.
how much I could have, had you all heard all the
No, that double effect. You were just telling about that double effect, that beneficence. That is where it stopped, dear.
let me continue with that. So the problem with palliative sedation is the double effect phenomena, whereas there is a beneficence versus non-malfeasance. Benefit of providing palliative sedation to relieve the refractory symptoms versus the side effects, like adverse effects of a drug itself, aspiration risk, and the respiratory depression risk. So it is very important that before you start the palliative sedation, the goal of care has to be discussed with the caregivers. One has to discuss with them regarding the pros and cons, and written and verbal consent has to be taken. Next slide. So it can be a respite sedation, and it can be a continuous sedation. In respite sedation, we'll give the sedation for 24 to 48 hours with frequent reassessment. That means we'll give the sedation to 24 to 48 hours, we'll stop it and assess whether the symptoms have improved or not, and then we can see what can be done. And it can be a continuous sedation, which is mostly used in the terminal illnesses with refractory pain and symptoms, provided till patient's demise. At the last, this is just the article which you can go through later on, which was a systematic review and thematic synthesis review regarding the experience of delirium in palliative care setting for the patient, family, clinician, and volunteers. Next slide. So this is the closure of the class for today. Are you all delirium ready? I hope you could have understood a bit of it. So what you're going to do to be well versed in managing delirium, you should suspect it, you should spot it, you should know and understand what is causing it, and you have to stop it and prevent it. Thank you.
Thank you very much, Dr. Parul. This is a topic see, everyone will be seeing these type, because it was all interactive. No? When you started off itself, they only gave all the possible causes and what they'll see. Thank you. That is the important thing. Being interactive in these sessions, the benefit is for all of you. Okay. Yeah. So anything you get reiterated, that will never be forgotten. So this is something many times you would have seen, but many times not diagnosed. Something, patient is not okay, just he's agitated, that something like that. 8 out of 10 times it will go like that.
Yeah.
We ourselves will give reasoning for that.
Yes, yes.
So identifying, and the main thing, many times what happens, like this is all what you say. Oh, from the caregiver point of view, it is very alarming because it will be a total change. Commonly you'll hear, oh, he's not at all like this. This is not him. So not him or not her. Oh, she is not a person like that. So that is what really scares them.
Yeah.
So they may even think, oh, they've gone mad.
True.
It's just a transient thing. Once that is solved, it will be the same person whom they know. So, and then the actual patient doesn't know many times that they did this. So that is what, like, I think I have had what I can't say nice experience. We had in our HDU, normally we have male patients, female patients separately. But in one situation, we had to have 4 patients. There were 2 male patients and 2 female patients. So we kept them far apart. But what happened, this male patient, that was a post-op patient. So he went into such state, we were trying to control. He didn't know what he was doing. He got up and went towards the female patient. So everyone got scared. So literally 2 nurses had to hold him and I had to give some medication to get him down. So when he woke up, he said, did I do that? Oh, so sorry. Why did I do that? That is what happens. So it is something very common. And if it is picked up and managed well, one patient will be happy and you will also be happy. Oh, see, we are not making them or the family go through distress. So now anybody else wants to ask anything, we will have few minutes for discussion and then we can take up the case. See, first, go ahead. Whoever wants to ask anything, unmute and ask or type in the chat. Choice is yours. How many of you practice palliative care already? You can just raise your hand.
Yeah. Manjeet Kaur has raised.
Only one person then. Toxic, there is just a message in the chat.
Denture. Yeah.
Or maybe they just added on, like, I think to your question of what were the causes. Okay, in that case, like there is a case, unfortunately. Sri Priya, is that person still not there who can present?
And Dr. Gigi had logged in, but I'm not sure whether she'll be able to present. She is in the session. I can see her name. But I think she's on duty as well. So.
Oh, okay. So somebody has asked informed consent. Yes, you've answered. Yes, see, this should be a combined decision. It will be a team decision. You will have the parent team. As Dr. Parul mentioned, there should be clear clinical evidence to say that patient is terminally ill and end of life care. So that comes a shared decision, exactly. That will come from the parent team and whoever is the palliative care physician looking after, and the family, because that is where many times trouble creeps up. Like the medical teams may understand we are doing good to the patient and not harming, but in the family, either the next of kin or like extended family, 8 may understand, 2 may not understand. So there will be quite a lot of eruptions going within the family. So for that also few suggestions. Either you can get the, I will say, and then Dr. Parul can also go ahead and explain. You can get the closest person, because see, explaining to all the 10 is one option. Or get the closest next of kin, or whoever is the next person for that patient, explain everything to them and ask them to go and explain to the rest of the family. Okay, that is option one. No, they say, no, they are already fighting with us. Okay, then we have no choice. Get them and then tell them, please listen to whatever I'm telling, because we want to have a proper, good conversation, not an argument and fight there. When we have a patient who is very sick and unwell, and so those situations, you say, I will explain everything to you, listen, then I will give you time for you all to ask questions, then I will explain, and then we'll take it from there. So these are the various options there. Time, room, space, everything. Give them time. They may cry, they may break down. Prepare yourself, have water, tissue, everything there. See, you have to do all this. We had in our communication sessions. How do you do? So all this has to be done appropriately. Then you go ahead and do the sedation. So that is the consent you get. And if you need to have and always I would say, have documentation for everything, because that point of time, everyone is in emotional distress. Okay, but everything will like 2 weeks, 3 weeks down the line, it may be different. So always all of you learn to save yourselves. Write everything with whom you discussed. You write so-and-so related to patient in this manner. What all I have explained. What have they understood? What did they respond to you? Please, it may be a one-page writing. If you do that, you are saved. And any day, document speaks. What you did is important. What you write is more important. Okay, Dr. Parul, you please go ahead and answer whatever you want to add on.
One question, is video counseling compulsory? No, it is not. Verbal and written documentation is well enough for documenting and taking the consent or counseling. If possible, you can go ahead with video counseling, and that too, one has to tell the attendant or whoever you are counseling that video consultation is there and it is recorded. And also going to add a few points, what happens is why it is problematic at the end of the life care, because it has a cultural impact also, especially in India. Many of the time, the caregivers want to say the last goodbye. And at this last moment, if you say that, okay, we are going to sedate the patient, and they feel, no, it is a part of the dying process, let it be like that only. We don't want anything else, because they don't have the idea and the understanding of the palliative sedation. And then you have to explain them completely what you're going to do and how it is going to help the patients, how it is going to relieve the distress also. That is why it is very important to discuss this beforehand, the wishes of the patient also from the caregivers, if the patient is not oriented or conscious enough. Yeah.
Just want to ask a question. What type of sedation, like we said, haloperidol and then followed by benzodiazepines, is there any sequence in which we can give the sedation? And what is the meaning of terminal sedation? Do a higher dose of sedation is being given to the patient?
There was a slide, no? She had one slide in detail. What is terminal sedation? What dose? Everything was there. Am I right, Parul?
Yes, it was. Let me just like repeat it again.
Exactly. If you want, we can get that slide also up there. That was very good.
But starting, we should start with haloperidol, or we should give benzodiazepines?
See, it is not about, it is the refractory symptoms which you are managing. Palliative sedation can be used for any refractory symptoms. Refractory symptoms of delirium, refractory pain, refractory any distress or respiratory distress. To delirium per se, refractory delirium, we have to see on which the patient is already on. If the patient is on haloperidol and you're not able to manage the patient on haloperidol because it is not sedative enough, then you will switch to the infusions. Infusion of what? Infusion of benzodiazepines. You can also start the infusion. Nowadays, we can even use the infusion of barbiturates or propofol also, right? So by increasing the larger doses means we have to start as a continuous infusion, not just giving the boluses and seeing the response. You have to control the symptoms enough. You have to give the infusion which is enough to control that refractory symptom. And that will depend patient to patient. Am I clear?
Yes, ma'am.
Yeah, thank you. Somebody has raised the hand.
Ananda, you can unmute and ask, please, Dr.
Yeah,
Chidananda.
There's nothing. It is related to the terminal sedation. What
Yeah,
I understand is basically, the thing is you should make the patient symptom free. Not that
yes,
sedation should be to that extent where it produces apnea or that will be implicated as the cause of the mortality. Patient should be able to be symptom free
yes,
and comfortable, and there are no signs of distress which should be seen. That's the aim with the terminal sedation. Like
yes,
especially if patient has a upper airway obstruction, that sort of obstructed breathing, all these things should not be there. That's what
yes,
is what I understand.
yes, yes. You're absolutely
Exactly. Exactly true. That is what has been said also. See, again, what was mentioned is you don't digress from the ethics. Okay. The four main ethics: autonomy, do good, do no harm, and justice of resources. These four things should be drilled and drained into our heads. None of them. We try to do all four as much as possible, one not intervening with the other. See, even if it intervenes, then you see risk-benefit ratio. Okay, so stage by stage, it has to be done. So if you do that in that way, you are also sticking to the ethics, explaining to the patient. As Dr. Chidananda mentioned, relieve the distress, because patient being in respiratory distress, patient being in delirium, agitated, moving hands and legs, that and things, no, that is distressful. This many times what happens, the patient doesn't know any of this at that stage of life. It is the carer and the family who are in more distress. But unfortunately, they may not understand. And very important point Dr. Parul mentioned is cultural beliefs. We have to give 200% importance to cultural beliefs and ask them, tell them, you explain. If they don't agree and they want to do what they want, that's what we may have to do. And there were a couple of questions in the chat box. And if it is home also, it can be done. And for that, I will ask Dr. Parul to mention, and then I will say what is done in Pallium also.
Yeah, I have not much experience of the pallium per se, but yes, that for the terminal or palliative sedation, home can also be the best place. And how do we proceed? We can proceed with the rather than this concept of subcutaneous infusion is adapted from Pallium India, where rather than putting an IV cannula, you can easily manage with the putting an IV in the subcutaneous area and giving that infusion using the infusion pump at the home setting places, where the family members will be taught how to change the syringes, and the healthcare workers or any social worker can be called at home to change that infusion pump.
There is one more question. Did you answer that also? And then we will.
Yeah.
There's one more question in the chat box. Does terminal sedation interfere with the golden experience of post-transition end of life experience?
This question, I think, ma'am, it's too difficult to answer.
No, see,
It's very difficult for me to answer. I have not.
no, this needs little bit of spirituality into it,
Yeah.
Parul. Don't worry.
Yeah.
I will answer 1 and 2 one by one. Okay,
Yeah.
if you're okay with it.
Yes, definitely. Please, ma'am, go ahead.
Okay, no problem. I will go through both. Okay, the first one. See, we like patient dying at home. No, I have done one audit when I was in intensive care, in between 2013 to 2015, where I looked because I did a lot of intensive care, end of life care. I did an audit with another consultant. So where we found 85 to 90% of the patients surveyed wanted to die at home. Okay, so that is the norm. Even, see, many times none of you should get offended. If we touch your hand and ask for yourself, what is that you would like? I would say, oh, I see you, no one allows me to come near, and so I would prefer to die at home. God's best gift would be for me to die at home. Okay, so that was the result of that study also. So that is what everyone prefers. So for that, so next is how do we get it done? So either like very good facilities there, you have option of going to hospital and having not being in ICU, but you have a room or something there. There also they will give subcutaneous infusion only, because that is the norm. Palliative care, hospice, everything is done as a subcutaneous infusion. Because when you do these type of things, palliative care abroad, everywhere you see, that is how it is. End of life thing are given as subcutaneous infusions. There are doses, everything given for that. So subcutaneous infusion is what is, and in that also you have different types. You can give subcutaneous, like intermittent subcutaneous also. But the best would be subcutaneous infusion. Only for that you need a pump. Really blessing to see is Pallium is able to do that. They load the syringes, teach them, and they have a home care team also called as an FST team. They have 7 home care teams going on a daily basis, of which one team is called as an fast track. Every day that team will have someone who is very sick. So if they already have someone who is on end of life care and who has the infusion, that team will see that patient. So there, this question of syringe driver replacement and all those, and then subcutaneous infusions, once it is done, it can be taught to the caregiver. And it's not like an IV infusion. It's not going to cause a bulge or anything like that. It will have little bit of raised appearance at the site, but it will not be like a big swelling or anything like that. So those type of things are taught to the family, what to see, what to watch, and take it from there. Okay, so subcutaneous infusions are done for end of life terminal sedation, and this is how it works. There again, this what is the stuff given varies from patient to patient. Young patient was in severe pain, was already in morphine. So that's why like one size fits all is not medicine. Okay, that is the beauty and charm of medicine, I would say. Always everything has plus and minus. So everything was simple. Why do someone needs an expert doctor? Everything can be done by one person, no? Then all of us will go waste. So that is how we have to look at it. So mastering everything and doing it for the patient, according to the patient. Their next thing comes is cultural. I will do one system and follow. I will be chucked out next minute. I have to do what? See, even in our day-to-day life, you would like things to be done your way. First day we will keep quiet, and next day we won't go there. Oh, when I go, nothing is done my way. Why should I go? We do that for little things. Always let the dignity and thing be continued till someone dies. Why should someone not get that dignity? So you have to tailor make and do it according to me. So even Dr. Kamakshi's query, What drug will vary depending on the patient. As I said, if it was a 30-year-old who was getting 60 milligram morphine 5 times in a day, you give 10 milligram midazolam, will that be enough? So it varies according to the patient, and we will do it according to that. So we'll do the best provided care as per the need. So we will, the whole dose, everything varies, and everything can be appropriately managed as per the need. So morphine, haloperidol, or midazolam accordingly will be given. And because even when I was there, we had a 35-year-old, I think, who had malignancy, like pelvic malignancy. She was talking, she had 2 children. We had to do everything. The family wanted some sedation, so we did give. So like that, it will vary time to time, and accordingly, everything can be dealt. And the infusion pumps are available there, so they do it. But if it is not there, also other options are intermittent, can be done. But for that and a little bit more home care team support and things will be required, or in hospital also can be done. Variety of these can be done. There are centers who do that. Okay, and now comes the tricky question. Okay, like terminal sedation interfere with golden experience of post-transition? For that question, Dr. Shivakumar, right? There, no, for that, how many, I won't take too much time. This is basically, many of us don't want to hear the word death. Okay, but death is certain. Happiness on. See, this is a little bit of spirituality. None of you should get offended or anything like that. In the good interest, as someone asked, and as I said, only 2 minutes. I won't bore any of you. Okay. See, death is something all of us are scared. Avoid. But that is certain. Us being happy all along is not certain. Someone can come and hit me next minute. I may be in sorrow with some injury or something. So like that is uncertainty. So like that, this experience, what Dr. Shivakumar has asked, it is individual. If someone says, no, that is why here advance directive, they are all very important in these type of situations. Okay, because someone might want that, but the next of kin or something may have a totally different idea. So it becomes what that person wishes may not happen. So if you're really particular that you want something done that way, you have to wake up. And I generally tell it in a nice, lighter note. When our top story is intact, please do all those stuff. If you get into dementia or something, nothing will help you. So if you really want those type of things, you have to have something already done. Think of, that's why, not only us, many elders, are very clear what they want, but some may not know. So in those situations, you will not be able to say anything. Has that answered your query, Dr. Shivakumar? Shivakumar only, was the person who had. Yeah. Okay, thank you. So, see, again, these are all very sensitive. That's why I say palliative care is a sensitive situation. That is why we give so much importance. Give value and respect for them, and then take it from there. So if they want it to be like that, we are not going to interfere. But if you explain, it all depends how much they understand and accept. And we have to be in good terms for that to realize. And next, one more thing I'll say. All of us read a lot of things. Oh, every patient will struggle. No, not at all. I have seen few patients. For example, again, I'll tell you one CA lung patient. She was only not even 60-year-old, 58, 59-year-old, who was diagnosed with stage 4 disease, but she was working full time. And that to what? She was she was working in a tailoring factory. So she'll work like 8 hours of stitching. her daughter brought her to us. And she said already because it was stage 4, medicines, like they tried chemo, in spite of being stage 4, they wanted. So they said they had done that 1 or 2 chemo given, no improvement. After the 3rd chemo or something, I think she was reviewed. And they said, so the daughter and mother had made up the mind that they are not going to go for chemo. So that's when they came to me. So I said, in that case, what was it? Pain relief. She was in agony. She said she used to do everything, work, cook. Now she's not able to do anything. So we started her on morphine. So with 5-10 milligrams and things, she settled with, I think, 10 milligrams 4th hourly. By 3 weeks, she was up doing everything. She didn't go to work, but she was at home, able to do everything. And like about 4th or 5th week, 2 doses, 1 dose we used to give for, first time we'll give for 2 weeks until she settles. And then 1 4-week dose we gave. Second 4-week dose she collected, and the next week she died at home. Morning she cooked, did everything. Afternoon or something, she had some little bit of distress and she died at home. So nothing, the pain relief was her main concern. And as I said, no, the second dose of full dose, what they picked up, they came and returned to us. So that the thing, no, I would say, don't think from what we read, everyone will die in distress only. It is not so. So those are other things. No, main relieving symptoms is the important goal. So those are many things. Many things are there. All what is said in the books is for us to know so that we don't miss anything. But every patient, everything is an experience. All of you will get. So next thing important, I say, you have to go to some center and go there and have hands-on experience for at least for 5 or 10 days. That will change the total outlook, and what you do, everything will be beneficial for all of you. Okay. So what is happening, Sri Priya? Is she there to present, or shall I go ahead?
No, ma'am, she will not be able to present.
Okay, then get the case on. Like, is anybody else wanting to do anything else? Or ask any queries? Or no, then in that case, we'll just go through with the case, Sri Priya. Get that case on and I will read it for them.
Okay.
Okay, go on to the next slide, please. 31-year-old, diagnosis of delirium, diabetic ketoacidosis, septic shock, dyselectrolytemia, type 1 respiratory failure. Next slide. 31-year-old male patient from South India came to the emergency room with generalized body pains, excessive tiredness, and confusion since last 2 days. Next slide. He had intermittent fever, generalized body pains, pain in left gluteal region since 1 week, but he didn't seek any medical advice. He was also noticed to have frequent urination, excessive thirst, dry mouth. And for the last 2 days, he became very tired and the symptoms worsened. That's why he was brought to ER. And he was a known case of diabetes since 5 years, was taking insulin injections, but he missed his doses since the past few days. Next slide. The vital signs were temperature 100 degrees, blood pressure 90/50, pulse rate 120 per minute, and the respiratory rate was 25 per minute. And there was moderate dehydration present. Patient was conscious but disoriented to time, place, and person. And other neurological examination was normal. There were bilateral crackles. Abdomen was soft. Cardiovascular sounds were normal. Skin was there was a tender swelling over the left gluteal region with purulent discharge. Next slide. The significant investigations in the intensive care unit were the blood sugars were high, hemoglobin 9, the white cell count 19, CRP 130, sodium 157, potassium 3.4, chloride 128, bicarb 18, pH was 7.24, PCO2 151, PO2 151, PCO2 30.5, bicarb 13, base excess 14, and culture sensitivity of the pus was Staphylococcus aureus in the wound. Next slide. What was the treatment given? He was intubated, mechanically ventilated, and extubated after 2 days. But still he was disoriented at times. BP was getting to normal, and all his vasopressors were brought down. Wound debridement and regular dressings were done. IV fluids were given. Insulin infusion was also started and following the whatever the regime should have been there. Potassium and magnesium sulfate infusions were given because he had all. When you would have seen the results, everything was quite abnormal, isn't it? And then antibiotics, IV meropenem and IV clindamycin were given with IV steroids, albumin infusion. Intake output chart was managed, and blood glucose was also monitored, and with the blood gases and electrolytes. Next slide. What were the medications given? Anything added on? Vasopressors, because his blood pressure was not okay. IV fluids, anything different alone, I'm going to say. All what was mentioned before, electrolyte correction, antibiotics. Next slide, please. What were the psychosocial aspects? Patient is an expat working as a manual laborer, and his chronic illness causing major impact on his work. So company don't, see, this is like local issues, because if he says he's unwell, the company will not want him to continue. So he would have avoided that. He is sad being away from his family. He's very depressed about the chronic illness and lifelong medication. Next slide. What were the main concerning issues? Impending job loss, financial issues, loneliness, and depression. Next slide. Summary. Here we have got a young patient with chronic illness, who is the breadwinner of the family, depressed with his chronic illness and lifelong medication, and presented with life-threatening complications. As a consequence of missing his insulin doses and lack of treatment for the infection, he developed diabetic ketoacidosis, severe sepsis and septic shock, and respiratory failure. Also, he was diagnosed with delirium during the course of his acute condition. And he didn't seek timely help because fear of loss of job and hospitalization. He was in a different place to what he is comfortable. Discussion points. Delirium developed during acute on chronic illness in a young patient. And he had defaulted with his medications due to depression and fear of drug-induced complications, financial struggles in a chronically ill person. Next slide. Okay, go back to the previous one. Basically, what were the things brought up were delirium and what was the cost for delirium and financial struggle. Come out of this, Stripriya. Okay, ideally, we generally request the person to present because little bit more question and things you want, it will be better. And always this case presentation is not only for the benefit of the person, it is for everyone. It is, I think everyone should take all these things. We are all not children, okay? So we should take all these things with due discipline. And when you're coming to attend a course or something like that, you take all the effort to do, and if you're not going to be there, no, that is not fair and square. I won't go more than that, because for a 3-year-old, I can teach. For all of you, I don't think I need to teach. You all will teach me 10 times. Okay, coming to this case was like the case presentation, what you had during our session today, what were the trigger factors that brought this patient to this condition? You can just type in the chat box or unmute and speak. Either way is fine. Oh, complete silence.
There were very simple training factors. Yeah.
Coming. Very good. Thank you. Metabolic disease, uncontrolled diabetes, yes, dyselectrolemia. infection. See, that's what one leading on to the other. It's a vicious circle, isn't it? Him not keeping his blood sugar under control. If always this blood diabetes, that glucose levels, even for pain, there is very many studies which have shown if your glucose level is going to be very high, whatever medication you give for pain relief, it will not work. Okay, because these are all studies which all through there is clear direct linear relationship which causes. So one getting that under control will get everything else. See, if for him if diabetes was controlled well, then infection, dyselectrolemia, dehydration, everything, the whole episode of ketoacidosis, sepsis would not have gone in. See, especially as being on insulin, he might have been a juvenile diabetic, not picked up or something like that. Many times family history would have been there and things taken lightly. Thank you. And on top of that, emotional instability, staying away from family, financial, yes, like an alien atmosphere. I don't know anyone around me, so I don't feel comfortable to say. So struggling here, loneliness or struggling within himself. Maybe he might not have got good friends with whom he is willing to open up. So many factors, multiple factors, which are all adding on to the stress, even though he is young. See, that is where everything is double-edged. Sometimes being young, can be helpful, can be detrimental also. So that way he might, that also could have led him to more depression and things. I'm too young, why am I struggling? So those type of things can creep up. So those were the young age with family responsibility, breadwinner. Yes, definitely. So the first thing was these were the trigger factors. And then his other psychological things were one leading on to the other. And him being in a totally different place might have upset him more. What were the facilities? What level? See, how much insurance and care money? Maybe whatever he's earning also, he might go off for his medical treatment. What insurance was there? So many factors are there when someone is unwell. So that is where having either the company looking after them, or at least if they have some good friends, and especially when he's not, as it said, it's an expat, so he may not know anyone. So that will cause more distress. Dr. Parul, whatever you would like to add on, please.
Yeah, so this patient had the precipitating factors and the predisposing factors, as you've already mentioned. And one thing important to see here is the medicines which he's taking, the insulin. It's again costly. It's adding to his burden, to his income. And along with that, he's only the breadwinner of the family. So we have to find the ways in which this person can be supported. Like we can include his family members. We can talk with his wife if he's married. I don't remember whether he had a family or not.
I don't think it was mentioned.
So yeah, we can include the family members and see how he can be managed, so that he shouldn't be burdened enough to feel that what he will do. Yeah.
That's all. Overall assessment. So how to first, now he has overcome and he was intubated, ventilated, extubated. So at least he is crossed the bridge for this time. We have to make sure that he doesn't end up in another episode like this. So he needs a lot of counseling, explanation, And men, from that point of view, I generally tell this is something all of you will be doing. See, diabetes and hypertension, no one needs to be scared. It is if you do everything properly, you can even avoid end organ damage and have a comfortable life. It's not like that you don't have any treatment option for that. So this is something we have to explain to patients. Only thing, it is not like fever, cough, cold comes and goes off. It just stays with you as a very good friend all along. So take it up like that and then look after that friend properly all your life, then you'll be fine. So many times what they think, oh, it's under control, so I miss those things. Their awareness, raising awareness. Even if he's young, teaching them. That is where, little bit more of care and thing we have to take for the patients. We have to make sure that they understand. Many times, many of them don't realize 300, 400 blood sugar normal, they carry on. Oh, they will miss medications. Even short trips they go, we have to teach them, raising awareness and teaching them the importance, and so that they avoid such episodes. And then this patient may need some counseling and things so that he understands the importance and he doesn't do this. Every time he has such episodes, end organ damage is going to be there. He's very young.
Yeah, the lifestyle modification has to be
correct.
And it doesn't need money actually. We have to tailor his lifestyle according to his lifestyle and then see. Yeah.
That's all. More of discussing, counseling. Those are things which will be what has to be done. There's some other message. Let me see.
I don't get
it. Very good. No problem. So that's all. So main thing is that we have to explain and make sure that he doesn't end up in a similar episode again. And then look into all possible factors. As she said, lifestyle modification, doing regular review with a diabetologist or endocrinologist so that that control is kept well, and explaining it to the family also, what will be best for him, and make sure that he has some friends who will look after him there. All that, every level, whatever can be done has to be taken and done appropriate. Okay. With that, in that case, I'll hand it over to you, Sri Priya. If anybody else has any queries, questions raised regarding this case or anything else from today, please do. Anup, in that case, you can, like based on, I think there are.
Thank you, Doctor. Thank you, Dr. Parul Raina. Thank you everyone for joining us. This is Anup along with Sri Priya ma'am and Dada ma'am signing off from Tipseco. Bye.
Thank you.
Thank you, Dr. Parul. Thank you very much. And thank you one and all.